Hey everyone, I hope everyone's enjoying their summer thus far and enjoying their clinicals. My literature review is on Down syndrome, so we'll get things started on page number 2 or slide 2, and we'll start out with the quote that I feel is very fitting for this subject. And the quote is, "I saw that you were perfect and so I loved you. Then I saw that you're not perfect and I loved you even more." Moving on to my next slide, and that is my objectives. I will discuss the history of Down syndrome. We will go over the prevalence rate on a national and global scale. We'll go over the pathophysiology involved in Down syndrome, go over risk factors for the development of the disease. We'll identify prenatal screenings and diagnostic testing, H&P findings, discuss potential differential diagnoses, explore treatment options and develop a treatment plan, identify pertinent patient education, discuss a follow-up regimen, and identify appropriate referrals and for specialties. So on the next slide, I'm going to go over the history of Down syndrome, and it's a genetic condition named after John Lungden Down, who was a medical superintendent who identified a group of asylum residents with common facial features. Initially, he believed this to be racially associated with East Asians due to the epicanthial skin folds. Early providers then referred to Down syndrome as Mongolianism. However, in 1958, a French scientist, Jerome Lafleur, identified chromosomal trisomy. With the backing from the World Health Organization, the term Mongolianism was no longer used and has been replaced with Down syndrome. So next slide, we're going to discuss the prevalence rate, and Down syndrome is one of the most common genetic conditions within the United States. It is reported that 400,000 Americans have been diagnosed with the disease. The prevalence rate is 1 out of 700 live births annually, and then it is estimated that 6,000 infants will be born in America this year with Down syndrome. Globally, 1 out of 800 children have Down syndrome. Next slide, we're going to go over the pathophysiology of Down syndrome. There's 3 predominant types of this condition with 3 distinct pathophysiologies. The first is non-disjunction or trisomy 21 of chromosome 21. In 92 to 94% of the cases, the condition is caused by non-disjunction occurring during the formation of the parent's gametes. The embryo results with 3 copies of chromosome 21 instead of the normal 2. In 90 to 95% of the cases, non-disjunction occurs in the formation of the mother's egg cell, and in 5 to 10% of the cases, prenatal non-disjunction is responsible for the problem. The next is translocation, also known as Robertsonian translocation. In 3 to 4% of the cases, the extra chromosome is part of the Robertsonian translocation, which occurs when the long arms of 2 acrocentric chromosomes fuse at the centromeres, and the short arms containing copies of ribosomal RNA are lost. The most common Robertsonian translocation leading to Down syndrome involves chromosomes 14 and 21. The third is macuism. It occurs in 2 to 4% of the children with Down syndrome. Macuism will occur. These individuals have 2 populations of cell, one with trisomy 21 and one with a normal chromosomal complement. Macuism results from either non-disjunction event that occurs sometimes after fertilization or from the trisomic rescue. The next slide will discuss risk factors, advancing maternal age being the first. A woman's chance of giving birth to a child with Down syndrome increases with age. This is due to having older eggs which have a greater risk of improper chromosomal division. The risk of conceiving a child with Down syndrome increases after the age of 35. However, research has shown that most children with Down syndrome have been born to women less than age of 35, but this may be due to the fact that former women under the age of 35 are giving birth. The second is translocation carriers of Down syndrome. Both men and women can pass their genetic translocation for Down syndrome to their children. 1/3 of the children with translocation have shown to have a parent with a carrier of this type of Down syndrome. The risk of reoccurrence of translocation is about 3% if the father is a carrier and 10 to 15 if the mother is the carrier. Genetic counseling can determine the origin of translocation. Having one child with Down syndrome uh, influences this. Parents who have one child with Down syndrome and a parent who have a translocation themselves are at an increased risk of having another child with the condition. Once a woman has been given birth to a baby with trisomy 21 or translocation, it is estimated her chances of having another baby with trisomy 21 are 1 in 100 up until age 40. Lastly, having a mother or father with the condition increases the risk factor. The chance for a female with Down syndrome to have a child with Down syndrome is 50%. When both parents have Down syndrome, the risk is up to 66%. So here's a nice, on the next slide we have a nice graph of sorts, a table that goes over incidence of Down syndrome, and it associates it with the maternal age. So on the top left, a maternal age of 20, the incidence rate of Down syndrome is 1 in 2,000. Now if we would jump over to a 40-year-old woman, the incidence rate is 1 out of 100. The incidence rate really does pick up once a woman hits age 35, as we previously talked about. So the next slide, we're going to go over screening and diagnostics. The American Congress of Obstetrics and Gynecologics recommends that pregnant women of all ages should be offered prenatal screenings and diagnostic testing for Down syndrome before 20 weeks of gestation. First and second trimester screenings include blood tests and a sonogram. The blood test measures the level of pregnancy associated with plasma protein A, also known as Papa-A, and the pregnancy hormone known as human chorionic gonadotropin, or HCG. Abnormals of Papa-A and HCG may indicate a problem with the baby. The sonogram looks for nuchal translucency. Sonography is used to measure the neck of the fetus. More specifically, we're looking at the width of the region of the posterior aspect of the neck. A measurement of 3 millimeters is considered abnormal. And next, we're looking at integrated screening. The integrated screening test is done in 2 parts during the first and second trimester of pregnancy. The results are combined to estimate the risk of the baby having the condition. In the first trimester, this includes a blood test to measure Papa-A and a sonogram to measure nuchal translucency. In the second trimester, the quad screen measures blood looking at 4 pregnancy-associated substances. The first is alpha-fetoprotein, 2 is estrol, C is HCG, and lastly inhibin A. Next, I will discuss cell-free DNA. This screening can be offered between weeks 10 and 22. Research has shown cell-free DNA screenings may be more specific and sensitive than traditional first and second trimester screening. During prenatal cell-free DNA screening, DNA from the mother and fetus is extracted from maternal blood samples and screened for the increased chance for specific chromosomal problems such as Down syndrome, trisomy 13 and 18. This screening can also provide information about fetal sex and Rh blood type. Diagnostics, so if any of the screening tests are positive or there is a high likelihood that the baby will have Down syndrome, diagnostic tests are available. The first is, I'm going to butcher this, chorionic villi sampling, or also CVS, much easier to say. Cells are taken from the placenta and used to analyze the fetal chromosomes. This cell test is typically performed in the first trimester between 10 to 13 weeks of pregnancy. The risk of miscarriage from a CVS is very low. Lastly, amniocentesis, a sample of amniotic fluid surrounding the fetus is withdrawn through a needle from the mother's uterus. The sample is then used to analyze chromosomes of the fetus. Amniocentesis is usually performed in the second trimester after 15 weeks of pregnancy. This test also carries a very low risk of miscarriage. Next, we're going to go over the history. And just bear with me for 1 second here. See if we got it all. Okay, yep. So history here, we're going to be looking at past medical, family, and doing a review of systems. A comprehensive documentation of the birth history should be obtained. When obtaining the history, we should make sure to inquire about any abnormal prenatal screenings or prenatal diagnosis of chromosomal abnormalities. Also, we should ask the family if there's any history of chromosomal abnormalities. When recording the history from the parents of the child with Down syndrome, the following should be included: prenatal concerns about hearing, vision, developmental delays, respiratory infections, and other problems. A comprehensive feeding history should be gathered to ensure adequate caloric intake. Any vomiting secondary to GI tract blockage by a duodenal web or estrase. Absence of stool secondary to Hirschsprung's disease also should be noted. We should note the concerns for developmental and cognitive delays, close attention to signs of heart defects including poor feeding habits, easily fatigued, and if the child is becoming cyanotic with feedings. Symptoms of sleep apnea should be reviewed, so these include snoring, restlessness during sleep, difficulty awakening, and daytime somnolence. So on the next one here, we're going to look over at physical exam findings. So these are not all the patients will have this with Down syndrome, but they may have many. You need a total of 8 to make a confirmed diagnosis. So brachiocephaly, upslanting preputial fissures, epicanthal folds, flat nasal bridge. They'll have a protruding tongue, short neck. You'll see extensive skin around the back of the neck. The extremities, they'll have short, broad hands, a shortened fifth finger. You'll see a transverse palmar crease, space between the first and second toe, as well as hyperflexibility in the joints. And these, on the next slide, we got 10 more common neonatal features, so including hypotonia, poor Moro's reflex, dysphagia of the pelvis. Those are a few more. So on the next slide, we actually got a picture of kind of wrapping all that together. So on the bottom right, you can see the increased space between the big toes. In the top right, we have broad and flat face, slanting eyes, short nose. We can see on the bottom left having an abnormal pelvis. You get that transverse palmar crease. We can see that in the top left as well. So knowing the clinical features of Down syndrome will help us differentiate this condition, especially if there was no prenatal screening done and a baby was not expected to be born with this condition. Knowing this information will be helpful to differentiate it between the next couple differentials I'll go over. So the next slide, we're going to talk about another potential differential diagnosis, and that's chromosome 9q34 deletion, also known as Kleestra syndrome. It is characterized by features including developmental delays, intellectual delays, severe limited or absent speech, and a weak muscle tone. Affected individuals have an unusually small head and have a wide, short skull. Distinctive facial features include eyebrows that grow together in the middle, widely spaced, a sunken appearance in the middle face, nostrils that open to the front rather than downward, and then a protruding jaw. Also, they can have rolled out, everted lips, and a large tongue. Affected individuals may have a high birth weight and childhood obesity. On the next slide, we'll go over our second potential differential diagnosis, and that's Zellweger spectrum disorder. It is another possible differential to consider. It is an autosomal recessive inherited multisystem disorder caused by one of 13 different PEX genes that are defects resulting in a defective proximal assembly and multiple proximal enzyme deficiencies. Physical findings include defects in the face, facial development, or in the eyes. Additionally, the eyes may be upslanting. The child may have a high forehead. Skin folds may present along the nasal boards of the space between the upper and lower eyelids. Hypotonia may be present, seizure activity, as well as jaundice. Moving on to our third and last differential diagnosis that what I'd like to discuss is Fragile X syndrome. Fragile X syndrome arises from genetic mutation in a gene on the X chromosome. The prevalence rate of this condition differs between male and female. Males 1 out of 4,000, females 1 out of 8,000. 80% of these individuals will have more than one of these physical features. But the presence varies between age and sex. Physical features are more pronounced with age, so we will progressively see these as these individuals age. So they are large and predominant ears, a long, narrow face, a predominant jaw, velvet-like skin, hyperextensible finger joints, a high arched palate, flat feet, and a sunken chest. Additionally, these individuals may be short in stature once they achieve adulthood. So knowing all that information, so how do we make the diagnosis? So like we talked about, the diagnosis is often established prenatally, but if it is not done prenatally, the clinician will have to assess the patient and confirm findings. A diagnosis of Down syndrome should include the presence of 8 or more clinical characteristics that we went through, and confirmation of these findings through a fluorescent in situ hybridization, also known as FISH, and karyotyping. FISH is used to locate and detect a specific area of the chromosome, including subtle missing, additional, or rearranged chromosomal material by labeling a known chromosome sequence with a fluorescent tag to see the location of the genetic material. Karyotyping is used to identify and evaluate the size, shape, and number of chromosomes. Karyotyping is essential in determining the risk of reoccurrence. In translocation Down syndrome, karyotyping of the parents and other relatives is required for proper genetic counseling. So, immediate concerns, management here. We can see that hearing problems, there's up to 75% occurrence, vision problem up to 60, sleep apnea 50 to 75, congenital heart disease 40 to 50, otitis media 40 to 70%, gastrinal alterase 12%, cataracts 15, hypodontia and delayed dental eruption up to 23%, and seizures. So going in a little bit more detailed for cardiac defects, it's estimated that 44% of children with Down syndrome will have a congenital heart defect. The following are the most common defects in decreasing order. So going from atrioventricular septal defect, ventricular septal defect, patent ductus arteriosus, and atrial septal defect. Additional defects include teratology of Fallot, polycythemia, and pulmonary artery hypertension. The long-term prognosis is best when an infant with a cardiac detection is promptly referred to pediatric cardiologist for medical management in order to prevent such conditions as pulmonary hypertension, or when it's a structural to a pediatric cardiac surgeon for early surgical repair. Looking at GI tract, you can have a tracheoesophageal fistula, Hirschsprung's disease, pyloric stenosis, annular pancreas, and a duodenal atreus. Additionally, Meckel's diverticulum and an imperforate anus. Immediate surgical intervention may be necessary to correct gastrointestinal tract disorders. Additionally, the rate of celiac disease is much higher in children with Down syndrome, which occurs in 3 to 13% of all, or 1,000 live births. By knowing this, children with Down syndrome should be tested after the age of 3. Musculoskeletal, they can have dislocation of the hip, scoliosis, patellar subluxation, joint and muscle pain, and rapid fatigue. These problems may occur throughout the child's life, and the primary care provider should be carefully screening for these at each visit. Looking at autoimmune or immune system function, children with Down syndrome have an altered immune function. Immune system defects directly contribute to an increased incidence and severity of numerous other conditions. These include periodontal disease, respiratory problems, thyroid disorder, lymphocytic thyroiditis, diabetes, and adrenal dysfunction. Children with Down syndrome are approximately at 150 times greater risk for acquiring acute myeloid leukemia and a 500-fold more likely to acquire acute megaloblastic leukemia compared to children who do not have the condition. Sensory defects, vision problems occur. 60% of the children will develop ocular deviations, with most developing multiple. They include slanted palpebral fissures, spotted irises, strabismus, nystagmus, cataracts, and pseudopapillary edema. Hearing loss can occur in 40 to 75%. Structural deviations of the skull, foreface, external auditory canal, middle and inner ear, along with throat accompanied with eustachian tube dysfunctions, are associated with congenital and hearing loss, which may be sensorial or conductive or both, and which can occur unilaterally or bilaterally. Hearing loss may greatly affect speech and cognitive development if not treated promptly with correct treatment. Respiratory complications, the complication of pulmonary hypertension, fewer alveoli, decreased alveolar blood capillary surface area, and associated upper airway obstructions such as lymphatic hypertrophy, hypertrophy. Why couldn't I say that word? I've said that word a million times. Put these children at higher risk for developing respiratory tract infections. Due to the anatomical differences in these children, they are predisposed to obstructive sleep apnea as well as other sleep disorders. Lastly, children with Down syndrome have increased frequency for seizure disorders. Up to 6% of those will be diagnosed with epilepsy. Of those with epilepsy, 40% will have seizures before they turn 1 year of age. Next slide, we're going to go to look at the cognitive function and how it relates, and it varies tremendously and cannot be established at birth. There is no relationship between the number of Down syndrome features present in a newborn and later cognitive function. IQs that have been reported from individuals with the condition range from low normal to profoundly retarded. However, there are reports of children with Down syndrome who have an IQ of 135 to 140, so probably higher than me. Early intervention programs can improve the academic prognosis for children with Down syndrome. Children with Down syndrome will pass through the normal developmental milestones, but at a much slower rate than expected. The nurse practitioner can assist in the child's development by referring the family to an early interventional program as soon as possible after the child's birth. Next slide, we're going to go over the management and follow-up, and we'll go in increasing age. So first, we're going to start with birth in 1 month. The American Academy of Pediatrics has published an extensive guide for the management of Down syndrome. It is important to screen the infant for many possible complications associated with the disease. We need to discuss with the parents concerns with feedings. Many infants with Down syndrome can feed successfully, but others will require supplementation. These infants also tend to sleep more during the day and may need to be woken up in order to feed. An echocardiogram should be performed on all infants with Down syndromes. As we talked about earlier, there's a high chance of valvular heart defects, and so all children diagnosed with this condition needs to be screened for this. We need to check for the red reflex at each visit, as these patients are more susceptible for cataracts. There is a risk for detection of GI abnormalities such as arteriostrace and stenosis. And then we need to also discuss about sleep apnea, bradycardia, and oxygen desaturation with car seat placement. So we need to make sure that these babies are prompted up and not laying down, just due to the structure of their body predisposes them for that. So we also need to screen for any hematologic abnormalities. That should be done within the first month of life, as well as screening for congenital hypothyroidism. Anticipatory guidance to parents should include giving names of local support groups, discussion of cervical spine precautions to avoid overextension or flexion of the neck. Infants and children with this condition are more prone to respiratory tract infections, so they should be evaluated as soon as signs and symptoms emerge. Also, we need to discuss early intervention therapies, as these should take place as soon as possible. Next slide, we're going to go from 1 year to 1 month. So hearing screenings, vision evaluations, and thyroid testing should continue and be performed throughout childhood. If the thyroid testing is normal on an infant, another test should be done at 6 and 12 months of age. Repeat thyroid function should be tested annually, even within normal limits. Infants should still continue to be monitored for any cardiac, stomach, or bowel issues. Patients should be instructed on the signs and symptoms of obstructive sleep. That includes OSA. Parents should be instructed on the importance of keeping the child's cervical spine in neutral position at each well-child visit. The child's growth should be plotted using the most up-to-date charts specifically designed for children with Down syndrome. Next slide, we're going to look at 1 year to 5 years. So celiac screening now is recommended if the child has GI issues, slow growth, failure to thrive, anemia, not amnesia, and or developmental or behavior issues. It is recommended that every child with this condition should undergo a sleep study by the age of 4, regardless of their symptoms. Hearing should be evaluated every 6 months until behavior testing can be conducted around age 5 and 6. Once behavior testing is completed, hearing tests should be done annually along with eye exams and also checking hemoglobin and thyroid function. Next, we're going to look at our 5 to 13 age group, and they will continue getting their annual hearing, hemoglobin, and thyroid testing, as well as getting their eyes examined every 2 years. The child should be observed for developmental and physical growth patterns, and school progress should be discussed with the parents or caregiver. Both the child and parents should be educated about the changes that will occur in the child during puberty and sexual maturation. Next, we're going to look at going into teenagehood and early adulthood. As the child progresses into their teenage years, into early adulthood, the need for routine evaluation remains. These include annual monitoring of thyroid function, hemoglobin, and hearing. Vision screening is recommended every 3 years in this age group. And just because the child was not born with a congenital heart defect does not mean we don't need to pay attention to this anymore. Valvular problems may develop as the child ages, and special attention needs to be paid to this. As the child enters into adulthood, we need to identify any high-risk behaviors and provide education and resources in regards to pregnancy and sexual transmitted diseases. Lastly, parents should begin thinking about their child. If they will need power of attorney once they become an adult, they should look at future finances if not already reviewed, and then dependent on the cognition status of the child, possible employment opportunities should be examined. So within the PowerPoint on the next slide, we're going to go over referral recap, and we went over quite a bit of different people we may need to refer. So a cardiologist, congenital heart defects, an ophthalmologist looking for absence of red light reflex, nystagmus, cataracts, or strabismus, an otolaryngologist for chronic ear infections for possible tube placements, an otologist for hearing and screening, gastroenterologist for dietary and weight control if there was ever any issues with the duodenal web or Hirschsprung's disease, neurologist if there's been any seizures, speech therapist for language and development as well as verbal communication, the primary care provider to be providing primary care management and referrals and parental support, psychologists for behavior and social problems, genetic counseling to determine if they're a gene carrier, social work, looking at group homes, independent living opportunities, and community support options for employment. So here are some helpful sites, not only for providers but for family. The first is the National Down Syndrome Society, and it is a hub of useful information for providers and family. The next is the local Down syndrome support group. It helps families connect with other families whose loved ones have this condition. I found that there was specifically one for fathers, and that's the Dad Support, and it allows for fathers to connect with other adults who have children with Down syndrome. Lastly, Little Hearts is a national organization for providing information, education, resources, networking, and stories of hope to family with children affected with congenital heart defects. So we started out with a quote, and I would like to finish with a quote. And acceptance is seen with your heart and not with your eyes. Down syndrome is the most common genetic disease in the United States. Incidence has increased from 1 out of 1,000 in 1970 to 161 out of 691 in 2007. Advancing maternal age has a result in this increasing the prevalence rate. Higher incidence rate further enhances the need for us to be educated on this condition and how to properly care for these individuals. Thank you guys very much for listening to me today. Have a good rest of your night.